Hello.
Hello, good afternoon, Chris.
Good afternoon, everyone. I always find the breakout rooms are in a bit of a state of flux because you start off with a handful and then your technique for running the session vastly changes as more people join. So I'll sort of start now since we are quite limited on time and let people join. I've just posted in the chat. So as I mentioned on the talk, I'm Chris. I'm part of the IT Innovation Centre at the School of Electronics and Computer Science, and we're a collaborative team. We work with people, clinicians, other data scientists at University of Southampton and other universities to solve problems. And I've already told you about some of the things that we've worked on, and really I want to sort of minimize the amount of time I spend talking in the next 15, hear about everyone else's problems, unmet care needs, potential data sets that could be used, and also other people's data science projects as a point of inspiration. So I'd encourage people to speak up, whether that be just on the chat here or posting a message. So even in this brief sort of snippet of time, we can connect, have a point to look back on. So yeah, are there any unmet care needs, any data science projects that others would like to highlight? I'll leave the floor. Go ahead.
I have a question. How do you link? Have you got any possibility of linking with the existing infrastructure in the UHS charts for sort of like creating databases out of existing data there for patients?
Yeah, absolutely. So we, the director of our group, Professor Michael Boniface, is part of the Social Data Foundation, which is actually interacting with UHS to centralize a lot of this data, because as you know, data is all over the place, and putting it in one place as a springboard for these kind of projects is a real headache. So they're working towards building a framework where we can put data in the same place and make it a lot easier. So I'd encourage you to look in that direction.
But what I'm finding is that I'm running lots of audit projects using students, and I spend a lot of time doing repetitive tasks that could be trivially automated if there was an easy way of pulling data from charts into a custom-made database, or even just having a database like linked directly to charts in some way. And what I don't know, what the charts backend looks like. I suspect that it looks like a mess of different age databases that just somehow have been.
So what kind of data are you working with here?
So I mean, basically, the patient data. So we've got patients with a particular condition or particular treatment, and we're trying to collect data, anything from simple survival, which is simply are they dead or alive, to evolution of different blood test parameters, whether it's anything as trivial as hemoglobin or liver function test, renal function test, you name it. And ideally, we would like to have a way of getting scan results. That's not possible to do automatically right now because of the way it's done. But even if you could just pull out the scan dates, then they could be annotated by the student or the researcher in that case for the particular given project. And obviously, in an ideal world, a lot of the information that we're collecting the hard way by reading the patient letters or notes and then sort of putting them into codified data forms could be done in like Proforma that you do on charts. Because increasingly that's what we're doing for a lot of our patient visits to try to standardize it for non-clinician prescribers. We've got, say, these are the toxicities the patient exhibited, grade 1, 2, 3, 4, this was the duration, and this can be put into forms. Right now, this is all just text-based forms, eDoc, Proformas. But in an ideal world, this would be something that we could just automatically enter in a database, producing a report for you, which can then be audited, searched.
Yeah, absolutely. So I noticed there's another hand up, Michael. If that your name's the right way around, I hope.
Yes, that's right. Hi. Yeah, I know it always comes up as George Michael on Teams. Always a good icebreaker, I suppose. But anyway, so I'm Michael George. Hi, I work at the Southampton Hospital Trust. So I just wanted to jump in there because the problem that you're describing, Ionis, sorry if I pronounced that incorrectly, is one of the problems that I'm part of a team that's trying to solve and trying to help with. So as a bit of background to myself, I'm a clinician, so I've worked as a clinician for about 10 years, but I'm actually transitioning to a technology role. So I work in the clinical data science unit at the Trust, which has only existed for the past 6 to 9 months. So a brand new and quite a small team. And essentially we're working to solve some of the problems that you describe, actually, trying to get that really useful clinical data out so that it can be used for clinical research predominantly, but also used for clinical audit as well. You know, it's trying to move away from that manual process of, you know, looking at data in charts and using the front end to actually being able to scalably get the data that you need and ensure it's of good quality for whatever research project that you're thinking of doing. So hopefully, you know, we can have a chat later and see if there's anything we can help you with.
Certainly, if there's any sort of automated process, or if you want me even to trial a process such as that, because I always have a couple of students every year who are in the process of doing these projects, and also a lot of our junior doctors will be very keen to carry out such projects, but are basically, when they face the practicalities of digging through charts to get the data.
Yeah. And I think you are right in terms of the actual data itself is a bit of a mess right now, and that's our main one of the main things that we're working on is trying to clean that data so it's actually useful for you know, to do the data analysis on. It's a database that's kind of been grown over about 20 or so years and passed through different hands, gone into the Trust and out of the Trust. So it's a big task, but one that we're working on.
And the interesting thing is actually the database, the front end that you show us is fine for single data collection. The problem is that if you try to, because of the time delay between clicking on one thing and then clicking on another thing, it adds up exponentially.
Yes, absolutely. Okay, I'm aware I've taken up too much time. So I think there's a few more hands up.
Yeah, hands go ahead.
So I'm a clinician scientist myself, in respiratory medicine, and we have two big data sets. One is from the WATCH study. I don't know if you're aware, Michael, about this. So it's the Wessex asthma or severe asthma cohort study. It's a prospective study where we collect data from our patients from a real-world clinic of difficult to treat asthma. And we have, with our data sciences team from the university, we have a database, an Access database, but we lost the person who actually has developed this. And it's very difficult for us to get somebody to get access to this data. So he exported most of it, and we're working now with a data sheet in SPSS, but we can't go back into this data because the person has left. So this is one of the problems that we have, and to interact, also get an interaction between the NHS, so that you at the University of Southampton hospital data, and pull more data out from these would also be preferable. This is the one study. The other study that I'm doing is the MEP study, maternal environment and pregnancy study at the maternity ward, where we collect data as well as samples from mums with asthma and without asthma who have a cesarean section. deliver the baby and also from the baby. And there's also big data sets. We use these samples now to do some omic data analysis, so transcriptomics, proteomics, and also the clinical data and different proteomic approaches. And we are now getting all the data back, and we need to integrate them with the clinical data that we have, but they're all in a LIA database, and then also connect them again with the hospital data that are on file in the hospital systems. So again, a similar problem than Ioannis has described, and I think this would be fantastic. And there are other groups within the respiratory, the COPD group and interstitial lung disease group, if we could have easier and quicker access to hospital data and combine them with our data sets like transcriptomic data, so RNA sequencing or proteomic data sets.
Yeah, absolutely. And just to follow on that from that, Hans, so we work on a project with Professor Tom Wilkinson to predict exacerbations for people with COPD, and it really is that interface of combining data where a lot of the problems lie, of what I would personally call data engineering. But I think that's a real area of collaboration to speed things up, so to speak. Hans, I wondered if have you used sort of smart technology in collections with this sort of tracking asthma?
No, not yet. No.
Would it be of interest? Because
Yeah,
this is
no.
something we're thinking about.
It would be of interest to use smart technology, particularly. We have lots of patients that have been started now on biologic treatments, so they had monthly or 2 monthly injections, and we need to somehow follow them up, but they do home injections. And some devices, smart way to actually collect the data from them and then analyze them and see actually how they respond to treatment. Because we do often a trial for up to 4 months or up to a year. And then based on the data that we collect from them, clinical outcome data or blood results, we need to make a decision if they can continue with this treatment or not, because they are quite expensive. So to have smart devices integrated with some software would be fantastic.
Yeah, absolutely. So I noticed we have a few people on the chat which may have made a conscientious choice not to speak up, but I would encourage them, if they, with the 2 minutes left, to come forward in text or through speech, either way. In the meantime, I think we've sort of talked about this interface of transforming data. Are there any other hurdles that we'd consider in the kind of projects we want to do?
Just want to echo whatever Ioannis mentioned just now, because one of my challenges is, we've got all data in all different software, and radiotherapy uses Mosaic, clinical uses charts, and then Histopath has their own sort of software. And how do we link all three to come up with something meaningful? Everyone's keen to sort of process them, but it's we sort of hit the wall when we try to figure out like how we're going to get all this three software to communicate. And it's just such a mammoth task that no one sort of willing to put their hands up to try to sort this. So that's one of my challenges that I'm sort of facing in my clinical practice.
Yeah. Ioannis, you're on mute.
I'm not sure you're the right person to ask this, but what about patient enter data? Who would, if we wanted to set up, say, as an app or web interface or whatever, to get the patients to input their own data in the system, who would be the best people to ask for help or advice with that?
So so one way we've approached this in our project, so we work with an industry partner, MyM Health, as a company, and they want to collect more information about patient records. And so in their app, they have an opportunity to link to NHS records as a way of getting around that. And in data governance, if they choose to volunteer their data, that's a way of getting a copy of the records directly from the NHS.
But no, what I meant was getting the patients to input data, so that like how they're feeling today, they've got temperature, they detect their own temperature, and if there's some way that allows us to get them to enter the data for us rather than us collecting the data. Well, you see
Yeah.
what I mean?
I'd say yes, digital health platforms and apps.
Yeah.
Yes, my medical records is from the UHS, I think one of the systems. And we have to set this up, I think, now for asthma as well, where you can have access as a clinician, but also if the patients want to, they can have access as well, and they can actually upload there some data as well. So it's my medical record.
I know that you could actually, the patients could see. I wasn't aware that they could actually upload their own stuff.
I think
what facilities?
They can add some things there as well, depending what you put on there. So if you have, for example, a questionnaire, they can complete for you a questionnaire.
Okay, that'd be interesting actually, because I wasn't aware that a bit of that, so I need to look into that. Thanks.
Do you know about this, Michael?
I'm just making sure I'm the only Michael on the chat.
Yeah,
so I'm quite new to the trust, but I have heard of My Medical Record. We haven't looked at the My Medical Record or don't at data, or kind of even started to explore it actually, because we have a lot of other things that we're working on at the moment, and we're predominantly looking at the database that's in the back end of charts. So EPR is what we're mainly focused on. So unfortunately, I don't really know much about the My Medical Record data at the moment, I'm afraid.
But this is a trust-based platform.
Yes, it is. Yes. Yeah.
In essence of time, I'd encourage us to go back to the main meeting, but please carry on the discussion. Don't let me cut you off. Thank you all for joining. Bye.
Thanks.
Thank you. Bye.